Thank you very much for this very interesting talk. Why, maybe you can explain this to us, why would you rather push than pull? What do you think is the advantage over a remplissage? Why do you do the subscap tenodesis and not a remplissage?
No, I'm not saying. I think that this is our theory, that we think that fixing the subscapularis on front, you can see on the scope that the head goes back. And we think that the remplissage pulls the head backward, so maybe it has the same effect because the humeral head goes back, and so you don't have a shifting of the head anteriorly, and so you can sort of neutralizing the lesion, the humeral lesion. But the main effect of this technique is to with the people that are hyperlax, to reduce the monosegmental hyperlaxity. When here now in the United States they do multiple ankle sutures, 5, 6. You know, in our country it's not very, first it's too expensive to put all these ankle around. Third, we have seen that dealing with this technique in this kind of patient, we have good results, and we don't have a complication in the way of doing the sports, or you can have redislocation if you do it when you have a bone loss that is pathology.
Do you combine it with remplissage?
No.
No, never.
Never, because you have stiffness of the
Okay.
shoulder.
What happens to the subscap once they do redislocate? Is that a big issue? Is the subscap
No, you can
torn?
It's a little bit different. It's not as regular than preserve, the one that you have because there is a scar tissue and stuff. But you can do a bone block, or I've done it after redislocation, a bone block or a so you can do everything you want after the technique.
Okay, one question, please.
Oh, sorry. Another thing is important, that you don't have less force of the subscapularis tendon after the procedure.
Just one question, because we have to go to the break.
What I wanted to ask Dr. Maiotti, regarding ASA technique. Thank you. Regarding ASA technique, should we tenodese the upper part of subscap, all of it? Does that play any role regarding subscap function and external rotation? What should we do?
The external rotation is a little bit limited, like every kind of surgical treatment. You have the treatment of external rotation. You don't find any ligament reconstruction. Even if you operate on the knee, you find a stiff knee. I'm not going to operate in a runner if he has a tear of ACL. He has to have a raise. So when you stabilize the shoulder, you have to have a little bit stiff shoulder. So you are happy if you have a little bit stiff. But if you do this technique, you have a mild limitation of external rotation. I saw you. And if the guy is hyperlax, you put into normal, because you have pathological external rotation in a hyperlax guy.
We've seen in your video that you arthrodese the upper part of subscap.
Upper part, yes.
Only. So the upper half.
I show you in the next video. This afternoon, I show you exactly where I put when I penetrate the tendon.
Why not the lower half, which is more important to the direction of the inferior?
I think that if you get all that stuff from inferior, you could have more stiffness.
Okay, thank you very much. Manos, should we go to a break or? Okay, so 15 minutes break, and we'll be back at 11:15.